Okay, hello there. This is Tailbone Pain Awareness Day. Today is November 15th, 2018. And the idea of Tailbone Pain Awareness Day is to get the word out that there's lots of people who are suffering from tailbone pain, and it's kind of a mixed message in terms of getting this message out for both physicians and also for and other healthcare professionals, physical therapists, etc., and also for the patients or people that are suffering with tailbone pain. I am Dr. Patrick Foye. I'm a medical doctor. I'm an MD, and I'm the director of the Coccyx Pain Center or Tailbone Pain Center here in the United States. And I'm online. You can find me at tailbonedoctor.com. And the idea of Tailbone Pain Awareness Day was really, thinking that there's lots and lots of people who are suffering with this and they don't know who to turn to. They don't know how to get answers. Their doctors don't know much about this topic. So really the idea of Tailbone Pain Awareness Day is to get the word out so that for physicians and other healthcare professionals that they can learn about the currently available tests and treatments that are now available, and also for people that are suffering with this so that you can maybe find some answers and better yet find some relief. The things I'll mention about this, right now I'm on Facebook Live with this on my page, which is facebook.com/Tailbone Pain Center. This is a public page, so I'll just mention that. So certainly if you make comments, I believe I'll see them as they come up, and maybe I can respond to some of those. I won't repeat your name just for purposes of the video, for your own privacy, but your comments will be on the public page. So if that's an issue for you, just use your discretion in terms of how much personal medical information you want to ask or on there versus keeping it a general question, nature type of question. Whatever works for you works for me. Right now it looks like we have about 3 people on, which is great for starters. And then this will remain, live for those who catch up with it later. Also, for Tailbone Pain Awareness Day, one of the things that we're doing is I do have the book available on Amazon for free for today and tomorrow. So the book is Tailbone Pain Relief Now. It is 272 pages. It is all about coccyx pain or tailbone pain. And we're making it free for Tailbone Pain Awareness Day, actually for today and tomorrow. So the easiest way to find the book and to get the book for free, this one is the paperback copy, paper copy or printed copy. The version that's for free is the electronic book. I would suggest even if you already have a copy of the paper book, pick up the electronic book, because that way you'll always have that. If you ever lose your paper copy or give it away to someone, maybe to someone else who's suffering from this or to your doctor or physical therapist, you'll always at least have your electronic copy. Easiest way to get the electronic copy, if you go to Amazon, so go to whatever the Amazon website is for your country. Here in the United States, it's Amazon.com, but it's whatever the Amazon site is for your country. If you go to that and just type in the search words tailbone and then my last name, which is Foye, so it's F as in Frank, O-Y-E. So if you type in tailbone and Foye, the book should come up for you there. You just select the book. So that's step 1. Step 2 is you have to select the version of the book. The initial pop-up will show you the paperback copy, which I think in the U.S. is about $10. You can get that if you prefer it in paperback. But to get the free version, just go to, there's a right above where it says Kindle Unlimited. If you have Kindle Unlimited, you can already get the book for free. But if you don't, you do not need to have Kindle Unlimited. You don't even need to have a Kindle or other, ebook reading device. You could read it even on your regular desktop computer. But regardless, it'll have a big button for Kindle Unlimited being free. But right above that, there's a little line that says select other versions or formats. And if you click on that, one of the other versions of the book, other than the paper copy, is the electronic book, and it'll tell you that the price is $0. So you can select that and choose that, and hopefully find and download that so that you'll have that for whenever it is that you get a chance to read it. So, but I would suggest grab it now during today and tomorrow while it's free for you. If you already have the book, certainly if you or if you pick up the book, it's great if you can post a review on Amazon, because that helps other people to find it. It helps Amazon to know that this is something that people are finding valuable. All right, so the other things I can see is some thumbs up coming through, so thank you for that. Some of the things I'll talk about here just for this live session. A lot of physicians don't know much about tailbone pain or coccyx pain or the coccyx in general. I attended medical school right here on campus. Right now I'm here in New Jersey, in the United States, and came to medical school here just a little over 30 years ago. Graduated from here over 25 years ago, so over a quarter of a century. And I have to say, in medical school, what we learned about the tailbone, you just learn that it's at the bottom of the spine, and that's about it. And that for some people it can be painful. But really, that doesn't help a physician much if they're actually treating someone with tailbone pain, because they won't know much about the details of what can cause the pain, or the test to get, or how to appropriately treat it. If people want, if you would like to post questions or comments down below, feel free to do so. If not, I'll just talk on some general topics related to tailbone pain. But just I will remind you, this is a public Facebook page for the Tailbone Pain Center here. So you can always, I guess, probably delete your comment afterwards or something. But while it's up there, it is publicly visible, I believe. So anyway, the thing about the medical education, it really doesn't give a lot of information to physicians who are training. It does not teach them very much about the coccyx or tailbone, and that's a problem because lots of people are suffering with this condition. So really, I've learned a lot over the last 22 years now that I've been in practice here, on faculty here, and roughly 20 years of that as the founder and director of the Coccyx Pain Center, or Tailbone Pain Center here on campus. I've seen a few thousand patients with coccydynia, and there are some common stories that patients tell. And one of them, unfortunately, is that a lot of them feel that their physicians, that their doctors, do not take them seriously, that their doctors do not only do they not know very much about the coccyx or tailbone, about what can cause pain there, about what the test to get would be, or any of that, but they also don't, it's a case where they don't know what they don't know. So they not only don't know much about the coccyx or tailbone, but they don't know that there are tests that are available, and that there are treatments that are available. So unfortunately, many patients are told, well, there's nothing to do for that, which is just blatantly, not true. So there are things that can be done for it, and there are tests that can be done to help figure out what's causing the pain, and then after that, figuring out what the best things to do would be to treat the pain. Many patients tell me that they felt that their doctors have been dismissive, that their doctors have been patronizing, or paternalistic towards them. That the doctors, in some cases, patients have told me their doctors have laughed when they've told them that they have tailbone pain. They think that there's something funny about that, in a way that they wouldn't laugh if a patient said, "Well, I'm having pain at my thumb, or I'm having pain in my neck, or at my knee." That physicians, just have, unfortunately, an ignorance in this area. As we all are, are ignorant in different areas. You wouldn't ask me to, fly a plane or to do your knee replacement surgery, because that's not my area. So really, then it's a matter of doing what we can to learn about the things that we don't know, or to refer patients, or to consult the medical literature, or help our patients to figure out what may be causing their pain and their issues. So really, that's where I started, again, roughly 20-ish years ago, on faculty here where I had a couple of patients who were suffering from tailbone pain, and I realized that I had learned almost nothing in medical school about how to treat such patients. So along those lines, then really it was a matter of educating myself, reading the medical literature, some things that had been published years and in some cases decades earlier, that really allowed me to start to learn more and more about what might be causing some of the pain and how we could best treat that. One of the most important things that I learned relatively early on was, and someone from Canada, hello there, good to see you on here. One of the things that I learned early on was the importance of doing the sitting versus standing x-rays. And this was first published by Dr. Main, Jean-Yves Main. Jean-Yves Main is based in Paris, France. He has an office right next to Notre Dame Cathedral and another practice as well. He has 2 sites in Paris. And he had the brilliant idea, it was a very simple and yet brilliant idea, that because patients are suffering with their tailbone pain, usually the pain is worst while they're sitting down. He had the idea to take the x-rays while they're sitting down. And it's very, very common that patients will have x-rays that look totally normal while they're standing up. And yet if you do the x-ray while somebody is sitting down, while the person is putting their body weight onto the coccyx, they will have significant abnormalities. So this is basically, I'll show you here, this is a model of the pelvis here, and at the lower part of the pelvis, right down here, you can see is the coccyx or tailbone, and at the coccyx or tailbone, it has this kind of gradual, forward curve to it. It'll be more obvious if I show you on here on this other model. So again, you have the sacrum up above and then the coccyx or tailbone here down below. And you can see how it has this curve to it. I describe it as being almost like the bottom of a rocking chair. So if I was doing sit-ups, I would essentially be rocking back and forth on my sacrum and coccyx. When you go to sit down, the coccyx has that gradual forward curve there. And what happens for some people is that when they sit down on that area, they'll have a dislocation, that their body weight pressing onto that area causes an actual dislocation or similar abnormalities where the alignment is no longer normal. And Dr. Main discovered this quite some time ago. It's almost 30 years ago now, first published in the 1990s. But basically, it's a long time ago. Certainly, at the time, it had not previously been published, and he had patients where he did the X-rays, found the abnormalities, and I would say that's probably the single most helpful, useful thing in terms of diagnostic testing that can be done. Let me just see a few of the comments here. Again, hello up in Canada. And someone's saying, wish that we took their insurance. Yeah, I'm in network with some insurance plans here. I'm an employee of the university here. We do accept charity care here within the state of New Jersey. Charity care here in the United States is a state-based program. So we're the #1 provider of charity care services in the state of New Jersey. And we're in network with all of the Medicaid programs. And in network with some of the insurance companies, but it's impossible to be in network with all of them. There's just too many insurance plans and insurance companies across the country, and patients fly in from all over the country. So some we're in network with, and some we're out of network. But even if you're out of network, if you call my office, they can talk to you about what some of the arrangements would be for that. Someone else says, and I'm not reading the names, by the way, just for your own privacy if this video is ever uploaded somewhere else. Hello from Ireland and Poland. Yes, hello in Ireland and Poland, whichever the two you are in or from at the moment. I've been to Ireland many times, have not been to Poland yet, but would love to at some point. And let's see, someone else says, I'm 2 years post-op, so post-operative after surgery, and worse off than before. So someone who's saying that they're worse than they were before surgery. I had many tests done, and the surgeon told me that it's just up to pain management now. So basically, the things I would say there, I have seen many, many patients who have had coccygectomy surgery done. Coccygectomy is surgical removal or amputation of the coccyx or tailbone, and basically with the with coccygectomy surgery, there are many patients, unfortunately, who still have pain that persists despite the surgery. So the things that can be done, for that. First and foremost, the most important first thing is to see if you can figure out what's causing the pain to be persistent. So along those lines, what I would say would be that probably one of the most common mistakes that I see is that even after the patient has tailbone surgery, they have ongoing pain, but they don't have any imaging studies done. The doctors just don't think to look at that. And it's kind of crazy because if a patient had a rotator cuff surgery, or if they had a cervical spine or lumbar spine surgery or a knee replacement surgery, and they had ongoing pain after the surgery or despite the surgery, in general, most physicians would think to have some imaging studies done and some diagnostic testing done in order to figure out why the person is still having ongoing pain there. And yet we see this commonly at the coccyx where someone has ongoing pain, or in your case, unfortunately, very sorry to hear, it sounds like you're worse than you were before the surgery, that the imaging studies or other diagnostic testing is not done to figure out why the pain continues. Sometimes it's as simple as getting a set of x-rays. I've unfortunately seen many patients where the original problem was not corrected by the surgery. So it's important before you have the surgery or before you have an injection to have a specific diagnosis made to try to figure out what's causing the pain in the first place so that you can make sure that the treatment is actually going to be something that's targeted specifically to that abnormality. So it can be important to have x-rays done. I can't tell you, I would say probably out of patients who I see for persistent pain despite coccygectomy, I would say the majority of them haven't had any imaging studies done to look at the surgical area, or they've had the wrong imaging studies done that failed to adequately visualize the site of the surgery. And there's all kinds of things. Sometimes I've seen bone fragments that are retained that are still there that the surgeon thought that they removed at the time. There's a number of different things that can cause this. I've seen cases where the area where they've shaved down the end of the amputation site when they amputate the coccyx, where there's been a very sharp, pointy area that's left there. There's been a number of things that we've seen. So that's just one thing that I typically look for in my patients. By the way, I will point out, although I'm responding to questions and comments here, I will of course point out that all of this is just for general medical information. This is not to be considered as specific individualized medical advice. These are obviously things that you need to speak with your in-person treating physician about in order to figure out what makes sense for you. Let me scroll down and see just other comments here. Hello from Australia. Terrific to hear from you. Hello, right back at you in Australia. Been to Australia, Great Barrier Reef, did some scuba diving there. Gorgeous country you have, obviously. I will ask, hi from Australia, I will ask for a sitting x-ray as nothing has been discovered why I have so much pain in my tailbone through laying down MRI. Exactly. So even an MRI, if the MRI is even done properly to show the tailbone in the first place, which unfortunately normally it is not, but even if it's done properly, typically an MRI is going to be done while you're sitting down. So again, it's not going to show what's happening when you put your body weight onto the tailbone. So an MRI, although it can be, way more, several times more expensive than a simple set of x-rays, at the tailbone, often it gives a lot less information, even if it's done properly to include the tailbone in the first place. I do have on my website, if you're seeing your doctor about having an MRI, I would strongly suggest that you go to my website and there's information there about the appropriate MRI to be done for the tailbone. So if you go to www.tailbonedoctor.com /blog, B-L-O-G. My blog page is there, and in my blog page in the upper corner, upper right-hand corner, there's a little search box, and if you just put in the word MRI, it'll pull up for you all of my blog posts, online articles that I've written specifically on there about MRI studies at the Coccyx, and it will go over some of the details in terms of the best practices in terms of having an MRI done at the Coccyx. It needs thin, midline, sagittal images in T1 and T2, and if that sounds like a foreign language, that's fine. It's just the lingo for how physicians and radiologists refer to the images that need to be done in order to properly show the Coccyx. Most of your radiology technicians, unfortunately, will not know about that. Most of your radiologists, may not think twice about that in order to have it done properly. But if you give them the proper lingo and talk to your ordering physician about that, he or she can evaluate for that, and if they're ordering an MRI, they can at least order it in a proper way that's more likely to give you the useful information. So that's in terms of getting the an MRI done at the Coccyx. Again, for a lot of these topics, by the way, if you have questions about tailbone pain, certainly you can post them down below here. But if you're looking for more detail and or information that you can print off and bring to your physician, if you go to, again, my website, tailbonedoctor.com/blog, B-L-O-G, and just in the search box, if you put in whatever you're looking for, if you're looking for something about EDS, Ehlers-Danlos syndrome, hypermobility syndrome, if you're looking for something about sitting standing x-rays, if you're looking for something about MRI or CT scan, or coccygectomy or pain after coccygectomy, and on and on. There's information on there that you can find the appropriate online articles that I've written there in order to find the information. So hopefully in Australia there and elsewhere around the world, you can get the sitting standing x-rays done. If you happen to be in France, of course, I would certainly strongly recommend that you see my colleague there, Dr. Main, in Paris, for his expertise at the sitting standing x-rays. I wish I could say it was that it was my idea, because it's absolutely brilliant to do the sitting x-rays, but that was from Dr. Main in Paris. All right, let me see. The next comment here says, after a year of pain and misery and a million doctors and no one believing me or knowing anything, I'm finally pain-free. Okay, awesome. Very glad to hear that. Makes my day to hear that you're doing well. Next one says, good, happy and healthy, good. I had problems laying on my back since my surgery. I can't. Thank you for addressing my issue. Thank you for everything you do. Very welcome. I'm happy to help wherever I can. That's sort of what makes the world go round. We all have times where we need people to provide education or information. Certainly, I've had that at times in my own family. Where I'm a big believer in primary care physicians and general practitioners. And then there's times where having a specialist can be super, super helpful. Particularly if you or a loved one have a condition that's less common, so that you can get the answers that you need. All right, let me see. There's another comment here. Let me try to read that here. All right, it's a little longer, so I'm going to sort of summarize because it's a little tough to read on my iPhone here, as I'm just have the iPhone propped up to do this Facebook Live. But this is someone who says that she's been suffering for 6 whole years. I've been told to manage my own pain. I had one GP tell me it was in my head, told me to stop wasting his time. That breaks my heart. That's terrible. And unfortunately, I hear that all the time from patients. And really, it's you would never hear a physician, I would hope never, but almost never hear a physician tell that to a patient if the pain was, again, it was in their knee or in their thumb or in their neck or some other place. But really, because the physician doesn't know much about how to treat pain at this specific area, that they end up essentially being dismissive like that. That's awful. But unfortunately, I hear that all the time from patients who travel to see me from around the country and even internationally. had several opinions regarding the coccyx, and after manipulation made it worse. So yeah, in terms of manipulation making it worse, the key thing is what was the diagnosis before the manipulation? Because manipulation, which is a way of mobilizing the joint. I'll show you. Actually, I can show you a few of the things I've been talking about that are in the book. Which, by the way, if you're just tuning in now, I did mention earlier. Today is Tailbone Pain Awareness Day. It's November 15, 2018. As I'm making this video, and for today and tomorrow, my book is free on Amazon. So I suggest you pop on over to Amazon and grab a free copy of the book while it's free. It's the electronic copy of the book is free anywhere in the world, any Amazon site for whatever country you're in. Just go to Amazon. In the U.S., it's Amazon.com, but it's Amazon in whatever country you're in. And in the search box, if you put in the word tailbone and also put in my name, which is Foye, it will bring up the book, and if you click on that, basically what you need to do then is just it'll give you the page for the book, and then just select. It'll say select other versions and formats, because the default is usually going to be the paper copy of the book. And but if you click on the other versions, then it'll show you the electronic version, which for today and tomorrow the price on that is $0. So it's basically free if you get it today and tomorrow. You do not need Kindle. You do not need a Kindle. You do not need to be part of Kindle Unlimited. It will try to ask you if you want to get it on Kindle Unlimited, but you don't need to. You don't need Kindle Unlimited at all. For today and tomorrow, it's free. If you have Kindle Unlimited, then it's pretty much, I guess, it's always free for you. Anyway, back to what I was saying here. So going back to the issue about manipulation. So I'm going to try to pull up that page here. Oh, by the way, I was talking about, well, here's just, to kind of show you, here's the spine, and the coccyx or tailbone is down at the bottom of the spine. And in terms of, again, these are just some of the images within the book. But basically, we were talking about the sitting standing x-rays, and one of the things that we see on those sitting standing x-rays at times, kind of what's shown on this image here, which is times when the plane x-rays may show a completely normal alignment, as shown here. And then, when the person sits, you may see that there's a substantial dislocation, as shown in this other image right here. And again, that comes from looking at the sitting versus standing X-rays, which essentially is done from a side view, while the patient is sitting to get the X-rays. So at any rate, we were just starting to talk about. I'm going to try to keep up on these comments here. But basically the question was about manipulation, and there is a chapter in here about manipulation of the coccyx, and basically the way that manipulation is done is the physician or physical therapist or chiropractor in some states will basically place one or two fingers inside the anus, and then typically the thumb on the outside over the coccyx. And manipulation is essentially, if this was the patient, and let's say that they are laying face down like that, one or two fingers inside the anus, thumb on the outside, and looking to mobilize the coccyx. So the issue with manipulation is it gets back to what was the diagnosis in the first place, just like the question we had about the surgery, or sometimes the question when it comes to injections or any treatment. What's the diagnosis? If the diagnosis is that the patient already has a hypermobile coccyx, which is the most common cause of tailbone pain, if the tailbone is already excessively mobile, then why would you want to mobilize it further, right? If it's already moving too much, then going in and basically rocking it aggressively back and forth, if that's the technique that's done, which sometimes is, to try to mobilize it even further, really has the potential to just make things worse in terms of the hypermobility. All right, so let me see if I get back to, let's see, some of the comments here. Going down within that comment, ligaments had sessions of electroacupuncture, so modalities sometimes are used for patients. No one seems to understand how coccydynia can affect your mobility or horrific pain. Yeah, it can really affect quality of life. For a bone that is, it's actually a series of bones, about half the size of the pinky. It is amazing how profoundly it can affect somebody's quality of life. All right, let me scroll down and see some, just because the comments are stacking up down below, I'll try to keep up on some of those. I was recently diagnosed with coccydynia after an x-ray showed that my tailbone was bent at a 90-degree angle. I have had nerve blocks and manual manipulation. Nothing works. Sitting, standing, laying, everything, walking, everything hurts. Again, the fact that the tailbone is angled at 90 degrees may or may not be the cause of the tailbone pain. Really, what I would be very interested in, if this was someone who I was treating in my practice or at the Tailbone Pain Center here, would be to see does the angle change dramatically while you're sitting compared with while you're standing. So that would be certainly something of interest to see, because there may be hypermobility there, and it may be that manual manipulation, as we mentioned a moment ago, maybe is not really the answer, or maybe there's something else going on. Again, these would all be things to think about with the treating physician. If the things that you've mentioned, manipulation, nerve blocks, etc., are not giving adequate relief, typically in my practice, again, this is something, this is not specific medical advice for you or anyone, but in my practice, I would usually be looking at then doing advanced imaging studies, so CT scan or more commonly MRI studies, in order to figure out why is this person not getting better, why are they not getting relief. So sit-stand x-rays first and foremost, which I'm guessing have not yet been done. But then if that failed to give an answer, then certainly considering an MRI would be another consideration. I have a number of folks saying, "Hi, Dr. Foye." Hello, right back at you. Good to see you all online. And let's see, someone says, "I'm in the UK and have been referred for a nerve block under anesthesia as blind injections have not worked. I've had a single standing x-ray and an MRI. NHS are hard work." Okay, so interesting. For those of our colleagues across the pond over in the UK, one of the things you can do is if you go onto my website to find out some about the NHS criteria. I have some of it posted on there because I've had a number of patients from the United Kingdom and have colleagues and that we've looked at patients together with. But basically, if you go to www.tailbonedoctor.com/blog, blog, and then that'll be my blog page. And in the upper right-hand corner there's a little pale box, and in that little rectangular box, if you just type in the abbreviation NHS for National Health Service for the UK, it'll give you all of my online articles that I've posted relative to the National Health Service in the UK, and in there are criteria for having sitting versus standing x-rays done and criteria for having MRI done. And it can be really, really helpful for you if you're within a given health system to know what are the criteria that the physicians or the other healthcare providers are operating under. Because your doctor probably doesn't know what the criteria are for the Coccyx. Just for reference, at some places have been quoted as that tailbone pain is about 10,000 or 20,000, somewhere in that realm, times less common than low back pain. So most humans will get episodes of low back pain. So here we have a model of the spine. The coccyx or the tailbone is down here. This is the sacrum. The lumbar spine or low back is up in this area. Almost all humans will have episodes of low back pain at some points within their life. most people will never have a day of coccyx pain. So if lumbar pain is 10 or 20,000 times more common, it's not surprising that your general physician and even your musculoskeletal doc and pain management doc and radiologist may not know much at all about the tailbone. So your local doc, whether that's in the UK at the through the NHS or elsewhere, may not really know what to advise you or what their own healthcare criteria are. So again, if you go to tailbonedoctor.com/blog, search for NHS, and it will give you some of the criteria there about. So basically, what I've done there is just copied and pasted the criteria for X-ray and MRI within the NHS system. Let's see. Next person here says, I have had doctors laugh at me before they found out I had my tailbone removed. Very hurtful. So many doctors in my area, Alabama, I've had a number of patients from Alabama, do not understand tailbone pain and are not knowledgeable. I pray one day I can get up there to see you. Yeah, it's unfortunately this is not specific to Alabama or even the United States or even North America. It's a similar problem worldwide where physicians don't take tailbone pain as seriously as they should. Again, I don't think it's typically meant out of intending to be mean or bad spirited or what have you. I think just that there's unfortunately a high level of ignorance and people think that it's funny somehow. If you think about it, if there was a high-level politician or a very famous celebrity and they had an injury to their thumb, or to their ear or to their coccyx, which of those would be sort of the brunt of jokes about it on, let's say the late night talk show comedy shows? It would be the coccyx or tailbone. There's something that people seem to think is funny or silly about that area, whether it goes way back to when we were kids and things like farts and poops seemed silly or funny. I'm not sure, but doctors unfortunately don't take the tailbone seriously. You can, if you search on either on my YouTube channel, which if you go to YouTube and I think on YouTube, my regular website is tailbonedoctor.com. I think on YouTube my channel is Tailbone Pain Doctor. If you look within my videos, there's a video or two on there about stigma and tailbone pain, or if you just go to my website, tailbonedoctor.com/blog, and again go to the search box and put in stigma, 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 and there's videos that I've done specifically on the topic and things that I've published in the medical literature for physicians to hopefully educate them specifically on the topic of the stigma and the bias and the insensitivity that many doctors and others unfortunately have regarding tailbone pain. So let me just read the rest of your question here. Okay. Someone says, my turn next week for the chop. And then it looks like a kind of anxious smiley face. Okay. And it looks like, hey, I've got someone watching from the Netherlands, a physical therapist, well known to me there. Good to see you. Watching. I met a lot of terrific physical therapists and other healthcare providers in the Netherlands this past June of 2018 at the Second International Coccyx Pain Symposium. So it was really wonderful. Being there. I gave some lectures and attended many more lectures to really learn about what different clinicians from around the world are doing in terms of their evaluation and treatment for tailbone pain. So great to have you logged in. So all right, let's see. Someone else says, do you find the injections to stop pain cause further damage? My first blind injection worked, but I'm in more pain now. I have a popping sensation since it wore off. Is it a case of injections for life or attempting removal? concerned that although injections provide temporary relief, that the damage will get worse. Maybe something that's answered in your book. I'll try to download it tonight. Yeah, there's a lot of information certainly in my book about injections and about the surgery as well. There's a so again, if you go to Amazon today and tomorrow, you can get the book for free, the electronic book version. And the first half of the book is really all about evaluation and testing and diagnoses. And then the second half of the book is all about treatments. And within that, you can see some of the chapters listed here if they display okay. But it's everything from different types of cushions to medications to manipulation, exercise, injections, surgery, etc. So basically, back to your question, as far as the injections, it really runs the gamut. There are patients certainly where I've had patients where you do a single injection that relieves their pain, and the pain may not come back at all, and it's been more than a decade and a half. Some of them I know because they live in the area here, and they still come into the practice to see one of my partners here, let's say for their knee arthritis or other things. But so for some people they have acute inflammation. You quiet that down with an injection or two, and they're doing fine. In other people, the pain may come back over time, and in other people, the injections may not be the answer. So really, there's no one specific treatment that will work for all patients with tailbone pain. That's true of the cushions. That's true of pelvic floor physical therapy. That's true of manipulation. That's true of medications by mouth. That's true of the injections. It's true of the surgery. If there's anyone who tells you that they get a 100% success rate in all of their patients, everybody who they've ever met for any condition is 100% cured, I would find that difficult to believe, as I'm sure you would as well. And in those cases, I would be very skeptical. It would make me more skeptical of that clinician. But basically. In terms of the response to the injections, back to this question that someone who's posted here, they report that they're feeling a popping sensation. Now, if you report a popping sensation, for people that have that popping sensation, typically I'm thinking that they probably have that instability, where the tailbone is in one position while the person is, let me see if I can hold this up okay to the camera, where the tailbone is in one position here, while you are standing up, and it's in a different position while you're sitting down. And the sitting-standing x-rays can show that. And if you would not be surprised then to see that these people may feel that popping sensation. I've had some patients describe it as feeling like the way it would feel if you cracked your knuckles. So they'll have that popping sensation at that area while they're, because that tailbone is unstable, that there's a joint or more than one joint where the ligaments are loose. And in those cases, the injections may quiet down the pain, but they may still feel that popping. Now, if that popping is mild and it's not painful, just like cracking my knuckles is not painful, then, fine. That's if your sitting tolerance is good, I wouldn't worry about the popping in and of itself. In general, if this was a patient I was seeing, of course, you need to speak to your own physician. But your next question is a case of injections for life or attempting removal. That's a very individual decision, of course, to make with your treating physicians. There are absolutely some patients where the best answer for them is just use a cushion and don't bother with any injections or surgery or anything else. If the symptoms are mild and if just a cushion does the job, terrific. If just a cushion doesn't do the job, then it may be worthwhile to think about other treatment options, and those may include local injections. There's a number of different types of injections. Again, the chapter in here that talks about injections, which is chapter 24, I believe. Yep, here it is. On page 181. So on injections for tailbone pain, there's a number of different types of injections. So, but I should say the biggest thing about injections is whether the person actually had an accurate diagnosis made before the injection was even done. Because if the injection is done, at one specific joint, and the patient had their problem at a totally different joint, then it would not be surprising that that injection may not be so useful for them. I cannot tell you how many times I'm going to say at this point, I've probably had, easily into the thousands of patients where, specifically where they've had an injection that was done where no specific diagnosis was even made before the injection. So they may have done an injection, let's say, at the top of the coccyx, but the person's problem was a bone spur down at the bottom of the coccyx. Or they may have done an injection at the bottom of the coccyx, but they have an unstable joint up at the top. Again, the comparison I always make is that it would be like me asking my mechanic, what's the best thing to fix if I have car problems? The mechanic would obviously know I don't know much about cars if I'm asking the question that way, because it would depend. Well, what is the car problem? Is it a fan belt? Is it a carburetor? Is it a spark plug? That's about all I know on cars, and not even much on those. But basically, so I have many physicians who will ask me at conferences and things where I'm lecturing. They'll say, what's the best injection to do for tailbone pain? And I'll always say, well, it depends. What diagnosis are we talking about, and what specific joint is involved if it's an abnormal joint? All right, continuing through. There's a few more hellos here. Some familiar names, which is great to see, and some new ones, which is also great to see. Let's see. Other things here. Hold on. There's some questions here about insurance for that. The easiest way, if you call my office, they'll have better answers for you, than I will on that. And let's see, there's a question here. If I know a doctor in Ireland who can help. Offhand, I do not, but I know that there was a physician, and I'm trying to remember what county in Ireland this person was at, that presented a poster at a conference a number of years ago on ganglion impar injections. So I don't know specifically. In the book, by the way, this is true for regardless of where you are. Maybe I should set up a clinic over there in Ireland, in Kerry or Sligo or someplace. Or Roscommon or Limerick or who knows. But basically there is a section of the book, a chapter here on called chapter 26, just called Working with Your Doctors. And there's information in there about ways to find a physician who can treat tailbone pain. And I can tell you the short version of, or a couple of tips from that chapter on working with your physicians would be the idea that if you call and you ask the receptionist, usually if the receptionist is the person who is scheduling all of the appointments, all of the evaluations, all of the injections, or all of the surgeries, or whatever it is that physician is doing, if the receptionist, if you call and ask, does Dr. So-and-so treat coccydynia? And they ask you, coxa what? What are you saying? What is that condition? Then there's a high likelihood that that office is not familiar with treating coccydynia, or that they rarely have a person with that. Otherwise, the receptionist would know about that. Similarly, if you ask them, does the physician do coccygyectomy surgery? If it's a surgeon, if you think it's really at the point where you need surgery. Fortunately, not necessary for most people with tailbone pain, but for some it may be. Maybe 2% or something. Or ganglion impar injections. Again, if the receptionist has never heard of any of these terms, chances are that office is not so likely to be helpful for that. Or if you just go to Google and put in tailbone doctor and then your geographic area where you're at, that may be one way to find people. All right, someone else is saying, thank you, you're welcome. They have apologized for leaving me waiting for 3 years. I'm not sure if this is our person from the NHS in the UK. I've lost track of the names here. And you're right about my musculoskeletal doctor is stuck, and I'll certainly have a look and print it all off. Okay, great. Someone says, I'm getting fed up. I imagine if my guided injection works, it would still be a long wait from it wearing off to getting the next one. Highly variable in terms of how long the injections last. So I had a patient a little over a month ago who I last saw more than a decade ago. Had done an injection for her. She had hypermobility, and on her sitting-standing X-rays, showed me the specific abnormal joint. I did a local injection there for her. She was fine for more than a decade, and then this past summer, her dog pulled her backwards and landed onto her buttock, and her pain came back. So she came back to see me when it wasn't getting better. So again, there are, it's variable in terms of the response. I see another friendly name from the Netherlands. So again, someone else who I met over there. Terrific. Good to see you here as well. Let's see, someone else concerned about nerve ablation and destruction side effects. Need more information about this. Yeah, I can certainly send out more information. Or there's information in the book about ablation injections, and then for patients where we're in the office treating, looking at that ablation, we go into more details. But the short version is that for purposes of this session, is that ablation is where we intentionally kill or deaden the nerves at a given site, whether that's for lumbar facet joint pain or for the coccyx for coccyx pain. And basically, what we're looking to do then is to kill or deaden the nerves that would normally be carrying pain from that area. So let me take a look. One of my models here. So there's different nerve pathways at the sacrum and coccyx, and depending on what's going on with a given patient, one option is to kill or deaden some of those nerves so that they can no longer carry the pain signals. So that's one option or consideration. Fortunately, it's not necessary for most patients, but if it's getting to the point where the more typical injections are not providing enough relief, then doing the local ablation injection there can be helpful and may give much more longer lasting relief in selected patients. Someone else saying, "Don't ever give up." That's good. Yeah, which is good to see people encouraging each other. Someone who found their doctor in Leeds, so another UK person here, and someone who's in Manchester, which I have relatives up around Manchester by Warrington. All right, I had my surgery 2 years ago. Surgeon went in, injected my coccyx, lidocaine for short-term relief to see if it was coccyx pain, and it did, and then said that the surgery should work, and it did when he injected it, but he went in, it was in 3 pieces, but like I said before, I'm worse off now than before the surgery. Yeah, so again, very unfortunate, and we see this unfortunately too commonly, where people will have the surgery and yet still have persistent pain, or in your case, unfortunately, where it's actually worse than it was before the surgery. There are things that can be done. I'm not a surgeon, by the way, so my approach is non-surgical treatments, and there are things that can be done after the surgery. Number one, figuring out why did the surgery not provide relief. Were there complications? Was there a bone infection at the site? Again, for more information that I can go into in detail in this setting, if you go to my website, tailbonedoctor.com/blog, BLOG, and then in the upper right-hand corner, there'll be that little search box there. If you just put in coccygectomy, it'll give you a number of online articles and some videos and things that I've done on coccygectomy, including answering some questions about why there's persistent pain after coccygectomy and what some of the treatment options can be for that. So there'll be information in there for you. All right, let me scroll down and see some of the other comments here. I think you should set up a clinic in Ireland and in the UK. As so far, the only medic that seems knowledgeable. Seems like I'm the only medic that seems knowledgeable. So yeah, I would. It would take some logistical doing, but I would love to get over to Ireland and the UK more often. So having a clinic there would be great for that. Logistically, it could be a little difficult, just given that I work full time at the university here in the United States in New Jersey. But maybe if I could somehow work out to do a working sabbatical, for a couple of weeks, once or twice a year, that would be lovely. All right, let's see. Someone else saying that their regular injections had not worked, but the ablation was their best decision ever. Someone else saying hi from Australia. So hello again. Someone else from Australia in here. Someone else saying they need to find a doctor in Michigan. Just got on. Hello, Dr. Foye. Hello, right back at you. Hello from Liverpool. I've had 3 different types of injections of all sorts. And efforts to remove the pain. None have even touched it. What other options are there? So again, I would say the first thing about response to the injections for me always comes back to what was the diagnosis in the first place. So again, it's very, 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 very common, unfortunately, where patients have injections but no diagnosis had been made. They've been given a diagnosis of coccyx pain or coccydynia, which just means that the person has pain there. So in some ways it would be like me saying, well, I have chest pain. If I have chest pain, that's not a diagnosis, right? The physicians would need to figure out, would I be having a heart attack, or was there a broken rib? Or is it muscular? Is it a cartilage? There's a number, is it indigestion from something I ate? With reflux, what's causing the chest pain? Similarly at the coccyx, what's causing the pain becomes an absolutely crucial cornerstone before getting to the injections, because figuring out why someone didn't respond to the injections if there was not a specific diagnosis made, again, it would be like trying to figure out why didn't it help my car, when I changed the oil or changed the spark plug, when really the problem was the fan belt. It had nothing to do with the oil or the spark plug or what have you. So really, that's number one. The rest of your question, though, what other options are there? So depending what the specific types of injections you've had done would be, and again, there's information in here about different types of injections that can be done. But really, first and foremost, of course, in my practice, I'd be looking back at what caused the pain in the first place. And then there is surgical removal, and then there's other injections that we do after surgical removal. There's pelvic floor physical therapy. There's a whole host of things that can be helpful. And again, a lot of that will be, there's 272 pages of information in the book. I don't think my voice will hold up towards being able to review all of that all in this one setting, but a lot of information in there. So I would certainly recommend, if you go to my website, tailbonedoctor.com/blog. The blog at my site has a lot of online articles that I've written over the years and videos explaining a lot of these things in more detail. So if you have a specific question and want more detail than what I'm going into in this public Facebook group or Facebook post here, Facebook Live, there's more information in there that hopefully will be helpful for you as well. I will make another comment just for maybe different people have joined in. I'm Dr. Patrick Foye. I'm an MD or medical doctor, and I'm the director of the Coccyx Pain Center or Tailbone Pain Center here in the United States, in New Jersey, just a couple of miles outside of New York City. And this is a Facebook Live session today for Tailbone Pain Awareness Day, which is November 15, 2018. And the idea of Tailbone Pain Awareness Day is to spread awareness and understanding and compassion about people that are suffering with tailbone pain, and spreading the word about the appropriate diagnostic tests and evaluations and physical exam findings and history and symptoms, and putting all of that into consideration to figure out what's causing the pain, so that then we can figure out what are the best treatment options for them. We've been talking about a number of those here. Certainly you can post your comments or questions down below. I'll get to as many of these as I can. I'm actually waiting for, I have, I think, 2 more patients coming to see me today. So I'm just, had a gap in my schedule, so I'm taking the time now to do the Facebook Live for Tailbone Pain Awareness Day. But in the meantime, I will say I'll read the comments down below with the 1 or 2 disclaimers or caveats being, number 1, this is a public Facebook page, meaning that your comments can be read or seen by other people. So use your own discretion in terms of the comments that you post. or sometimes people I'm not sure if you can then delete it afterwards, if it's something I've answered for you. That's, whatever works for you is fine by me. And typically, as I'm reading through your comments, I'm not going to read anybody's name, just out of respect for your own privacy, so that if this video if I ever upload it to YouTube or any other platform, that I'm not giving away your specific personal individualized information. And then the last disclaimer I will make is that the comments here are meant to be educational, right? So obviously you need to speak with your in-person treating physician to make any decisions about your own health care. So you talk to your own healthcare provider. All right. My doctor has seen with ultrasound that there's a misalignment and then a bulge on the next bit of my coccyx. I'm hoping, he says, that they will remove it. Depending what's causing that bulge, and whether that's bony, like a bone spur, or whether that would be soft tissue, like like a pilonidal cyst or other conditions, and whether to remove it or not would depend again on what's causing that malalignment and what's causing that spur, and whether surgery is actually necessary or not. For most people, with tailbone pain, surgery is not necessary, but there's a small percentage of people where it is, and there are patients indeed who I do refer for surgical treatment. Can patients get a consultation with you without coming to New Jersey? Currently, no. Unfortunately, the way that medical licensure works in the United States is that you're licensed, although you pass your national board examinations and all of those things on a national level, the licensure is specific to the state that you're in. So I'm licensed to practice medicine within the state of New Jersey. There are some things on the horizon in terms of telemedicine, which is a way of having online consultations, so things that almost like through a video conference call that would be patient privacy secure and those kinds of things. So the laws are and regulations are changing to allow that to be more accessible for people, and I think that that's a great thing when that comes along and when that advances and expands beyond what it is now, so that we can reach out and help more people, because I know that for every one person who gets in a plane and flies in to see me, there's probably 100 more people who need advice and counseling and expertise that don't have the time or the resources or someone to find that or someone to watch their kids or cover for them at work or take the time off to come and see me. So I'm certainly looking into that. Have you dealt with someone who has no segments? I've dealt with chronic pain since 2014. So I think if you probably what the person means in this question with no segments, meaning that there's no joint spaces, that the coccyx is entirely fused. Absolutely, I've had many patients who have had the tailbone entirely fused. Let me show you on here. So there's variability at the coccyx, right? So this is the lumbar spine, here's the sacrum, down here is the coccyx or tailbone. And there's variability in terms of whether the individual segments are fused together or whether they have a patency or a joint in between them. In this particular model, it basically is showing a joint space at the sacrococcygeal joint right here, but showing the rest of the coccyx being fused. But back to answering this person's question, which is, there's times where there's no individual segments. The entire coccyx is fused as a solid bone connected to the sacrum. And in those cases, there's no mobility there. It doesn't have the ability to move out of the way. So when you go to sit down, normally when you're sitting, what happens is that when you go to sit, the tailbone flexes forward, a little bit. And if it's fused, then it can't really move out of the way, and that can be a source of pain, especially if that's in combination with, in many cases, there may be a bone spur down at the lower tip, and that bone spur is going to hit the chair or the seat or the couch that you're sitting on, and in those cases, when it hits there, instead of the tailbone being able to flex forward and get out of the way, it's essentially stuck, pointing or pressing, your skin straight down into the chair. So that can be, a significant problem. Again, this can be treated depending on the specifics. So certainly things to consider. All right. Next year, you'd like more time to advertise for Tailbone Pain Day, Tailbone Pain Appreciation Day. I certainly agree. So it can become better known. Despite this symposium in the Netherlands, there's still a lot of incomprehension. Absolutely, and so I completely agree. So the idea for this year was just to sort of get the ball rolling. And I picked November 15th for Tailbone Pain Awareness Day. Basically, I did it mathematically. This is on my blog as well. But I went through and I looked at if you count up all of the vertebral bodies throughout the spine. So on the wall behind me here, there's this model shows, or this poster rather, shows the entire spine. If you look at the cervical spine, the thoracic spine, the lumbar spine, the sacrum, and then the coccyx, if you ignore the coccyx, you're ignoring the lowest 3 to 5 segments, and proportionally that would be like if you average that out over a 365-day year, it would be about the equivalent of ignoring the last 6 weeks of the year. So that's how I came about picking November 15th for Tailbone Pain Awareness Day, kind of with the idea that for physicians that don't think twice about the tailbone or don't take it seriously or think, well, it's just such a small little thing, why should we even bother to think about it or be concerned with it? It would be similar to saying, well, why would you care about the last 6 weeks of the year, right? It's just that terminal end. What's the big deal? Just focus all of your time and attention and energy on the entire rest of the year, and somehow go into a coma or a slumber, and miss all of the November and December holidays and all of that. So again, that was kind of the idea, and really for this year is just to have a date started, to get the conversation going, to make the book available. There's been a few things. The New Jersey Society of Physical Medicine and Rehabilitation has recognized this as Tailbone Pain Awareness Day as well, in recognition for how many patients have traveled here to New Jersey over the years. But certainly for next year, my hope is that every year that it gets bigger and bigger, and that we get more and more international involvement. I certainly have fantastic colleagues around the world, including pelvic floor physical therapists and musculoskeletal physicians, pain management doctors, and surgeons, and others. That it would be great to have kind of a number of different things going internationally. All right, so next question. After removal, do you have to be careful causing further damage from things like snowboarding, rowing, yoga? In general, it varies. So there are some patients who, after they've had their coccyx removed or have had an injection or any other treatment, they're able to go back to all the same things they used to be able to do before. So I've had patients who've gone back to riding their motorcycle and doing kayaking and snowboarding and yoga and cycling and all kinds of other things. And but I've also had many patients who have said, who have either decided not to do those things, or they tried them and found that it really was not worth it for them, that it flared their pain back up. So really that's an individual decision, of course, and it varies from person to person. All right, does nerve ablation help for hypermobility? So for any of the injections, they can help for hypermobility, which is excessive movement at the tailbone, if the injection is done at the proper location. But it varies, of course, from person to person. For a nerve ablation, which again, for those who may just be tuning in now, nerve ablation is that deadening of the nerves, and for that, basically, it's important to first diagnose what's causing the pain in the first place. If it is hypermobility, what specific joint, and then looking to target the nerves from that joint if it was going to be an ablation type of injection. Okay, someone else is talking about using tramadol and Tylenol, or Tylenol rather, and tramadol to manage their pain. For that, just to be cautious, there is one version of tramadol that has some Tylenol in it, which is tramadol in the United States here, there's by a trade name of Ultram, and there's a version of that called Ultracet, which has acetaminophen within it. So if for people, if you are taking pain medications and you're also taking Tylenol, just double check to make sure that the regular pain medication you're taking does not already have Tylenol or acetaminophen in it, because you don't want to accidentally overdose because you're thinking you're taking the standard dose of Tylenol as straight Tylenol, but not realizing that Percocet and Ultracet and Darvocet and other things have acetaminophen within them. Here's someone who says, I have ongoing coccyx pain since I fell pregnant in 2016. Actually, for that, before I even get to the question, I'll just mention for that tailbone pain associated with pregnancy, very, very common. Saw another patient today with this, and very, very common. So the issues start to become figuring out what caused it. Was it during the pregnancy itself, during labor and delivery? I've had patients who've had fractures and dislocations while the baby is passing through the birth canal. So again, back to grabbing one of our models here. So this is a model of the pelvis. And basically, here you can see, looking, through the bottom, of the pelvis, so the pelvis would be like this. If this is the head of the baby passing through the birth canal, you can see here, if I hold it up correctly to the camera, you can see kind of what's in the way. In terms of as that head and shoulders of the baby is passing through the birth canal, it can cause trauma right here to the coccyx. So for many women, that's the start of their tailbone pain, is during labor and delivery, and then there are issues about what to do with subsequent pregnancies and how to treat that. Let's see. Someone says nothing, and she says nothing showed regarding my coccyx on the MRI. Again, the question is, was the MRI done properly? Did it include the tailbone? Usually it does not. And if it did include the tailbone, was it done properly with thin T1 sagittal images? Again, if you're looking for information on this, if you go to my website, tailbonedoctor.com/blog, and in the search box put in MRI, it'll give you a lot of information about whether the MRI visualized and showed what it was supposed to show. And then this person is saying that they had a steroid injection, and they're keeping their fingers crossed that it will work. So certainly we're hoping for you as well that will that will give good relief. Here's someone who's saying my next question here. My iPhone is telling me, by the way, that I'm on low battery here, so I'm down at 20%. All right, so hey, doctor, my 6-year-old daughter has spondylolisthesis. Is there any way that this can heal itself? So as a physician and also as a parent, my heart goes out to you and your daughter, your family, for that she's suffering with something like this. There is it can be quite challenging. So there are certainly. There are many times where the person with tailbone pain may indeed be a child. I've had patients as young as around 2.5 to 3 years old, and as old as into the 90s. So I have a number of pediatric patients with tailbone pain, and the issue really comes back to some of the standard things that can be done to treat that. There is one of the last chapters in the book. I'll pull up here. Is about children and tailbone pain. So if you do grab a copy of the book, while it's free, particularly today, or if you get it some other time, but today and tomorrow it's free on Amazon, then certainly that chapter will be of interest to you. But for many people, for the vast majority of children, there is relief and treatments that are available. All right, next person here says they're diagnosed with rheumatoid arthritis, originally diagnosed with juvenile rheumatoid arthritis, bad sacroiliac joint pain. They've done many things, including ablation. Can RA cause this pain, or is it more likely something that happened since giving birth, pain increase since then? Tailbone pain has been associated with some rheumatologic conditions, probably one of the most common ones is something called EDS, or Ehlers-Danlos syndrome, which is a hypermobility syndrome. Ehlers-Danlos is a syndrome where people have ligaments that are very, very loose. It's a connective tissue issue. So these people can, often extend their fingers and their wrist, all the way back, and they have joint laxity, and that laxity includes, laxity at the joints at the tailbone as well. So that can be an issue and a concern and a problem, for patients, to have that hypermobility there. And so now back to your question, which was specifically about JRA and RA, juvenile rheumatoid arthritis and rheumatoid arthritis. Rheumatoid arthritis can sometimes affect the spine, and it's possible that someone may have rheumatoid arthritis involving the coccyx. Again, it would depend on looking at the actual imaging studies. Rheumatoid arthritis has some characteristic appearances on X-rays in terms of some of the erosions and findings that occur at the joint spaces, and it would be a matter of looking to see, is that going on at the tailbone, or is it something completely different? Maybe it's a bone spur or an unstable joint completely unrelated to the arthritis. Let's see, other things. Someone says, pain started after weight loss surgery, substantial weight loss. Is this common? Yes. I first published on this many years ago, and the issue there is that there's no muscle tissue or padding directly behind the coccyx. So we have our gluteal or buttock muscles, here on each side. But there's no padding at the tailbone. And then what can happen when somebody loses a lot of weight, especially if you lose a lot of weight very, very quickly, you lose a lot of the padding at the other areas. And then the tailbone starts to hit the chair when it maybe has not hit the chair in many years. So we see this where someone will have, let's say, for example, a gastric bypass surgery. They have a surgery as part of their weight loss. It'll be a surgery where there's either a stapling to make the stomach smaller so that you cannot eat as much food at one time, or there'll be a gastric bypass. So there's a number of different surgeries that can be done for weight loss purposes. And these can be profoundly life improving for many, many people. Or sometimes somebody will just lose weight without the surgery, of course, just with an aggressive diet and exercise program. And I cannot tell you how many of these patients almost verbatim say the same thing to me. They say, Dr. Foye, since I've lost 120 pounds in the last year, or 100 pounds, everything about my life is better, except now I have tailbone pain. And often it may be something as simple as a bone spur down on the lower tip of the coccyx, but that bone spur has not been hitting the chair for the last 20 or 30 years that it may have been there, because there was a lot of soft tissue, from the person's body weight. I've had patients who have weighed, 300 pounds, 400 pounds, even 500 pounds. For those of you in other countries that use the metric system, it's 2.2 kilograms or 2.2 pounds per kilogram. So obviously, if you have a 500-pound patient, that's a very heavy patient. But if they lose 100 pounds or 150 or even 200 pounds, now the tailbone may start to make contact with the chair, and for these patients, they'll say, "Boy, everything else is doing better. I'm off of my medication for my diabetes and for my blood pressure, and it's under control. And my blood sugars are great. My energy is great. I'm sleeping better. I no longer have the sleep apnea. My love life is better. My endurance. I can walk up a flight of stairs. I'm not getting short of breath all the time. All of these things." Except now they have tailbone pain. The good news is that it can be treated, just as with any of the other tailbone conditions. It's a matter of making an accurate diagnosis about what's causing the pain, and then figuring out what's the best thing to do to treat this. All right, someone says, "Thank you for taking your time to do this video." You are very, very welcome. I'm happy to do it. I enjoy collaborating with clinicians and with people from around the world. Facebook Live is a cool way to do that. Yeah, so happy to be here. Let's see. Besides the awful pain when sitting, I also have a flare-up of pain if I bend over several times a day or lift anything, even if it isn't heavy. Is that common with coccydynia? So I would say it's not particularly common, but it does happen. So the question basically is saying, the classic is tailbone pain with sitting, that when you sit and your coccyx is, again, we'll go back to making this as like a chair here. If you're sitting and the tailbone as you sit is making contact with the with the chair or the seat that you're sitting on, then that can be very painful for you. So that's kind of classic for tailbone pain. But we know with more than 7 billion people on this planet, there's variability from person to person. So there's the things that we teach our medical students when we're introducing them to an idea. We try to keep it very focused and make it sort of the most classic textbook case of presentation. And then there's what we see in real life, which is variation from person to person in terms of their symptoms and how that presents. So for some people, yes, it's the pain. I get pain, but I also have some pain when I'm standing or walking or when I'm lying down. So it is a matter of variation from person to person. And to figure out whether it's really coccyx pain as the cause of it, the less classic things you have, if you have something that happens only 5% of the time, let's say with tailbone pain, then I would say, okay, well, maybe the diagnosis is a little bit suspect. Maybe it's not really coming from your tailbone. Maybe it's something else. So looking further, whether on the imaging studies, again, it's always a matter of correlating what we see, what we hear from the patient's symptoms, number one, first and foremost, most important. Number two, from the physical exam findings, where is it that they have their tenderness, and localizing specifically where at the tailbone, if it's tailbone pain at all. Number three, what do the imaging studies show in terms of, and does that match with the symptoms that they're having and the physical exam findings? And then number four, how do they respond to treatment, at a given spot? All right, someone else saying hi. Hello, right back at you. Thank you for doing this live. Nearly 5 years of this awfulness that is coccydynia, and 2.5 years status post partial coccygyectomy. So you're very welcome for doing this live. I'm happy to be on live with you. And 2.5 years out from your partial coccygyectomy. So just to explain that for others who may not be familiar, when the tailbone is removed, again, here's our model of the lumbar spine, sacrum, and then down here is the coccyx or tailbone. When the coccyx is removed, it can be done as a partial coccygyectomy or a complete coccygyectomy. If it's a complete coccygyectomy, they remove the entire tailbone or coccyx. It's basically amputated. And for a partial, they only remove part of it. And there's debate as to whether you should have if you're having coccygyectomy at all, which fortunately most people do not need. But some people absolutely do need it, and it can be quite beneficial. And there's people who I send for consultation for coccygyectomy. Every year there's a number of patients because, again, although the vast majority of people respond well to non-surgical treatment, unfortunately, it's not 100% success, so it's not 100% of people who do well without surgery. Some do, in fact, need it. But anyway, so a partial coccygyectomy would be removing part, complete coccygyectomy removing all of it. And again, it depends on what was the original diagnosis in the first place, and are they removing the proper segment, if it's a partial, to get the relief that the person needs. It's ironic that you mentioned hypermobility. My doctor mentioned that recently. So good. So your doctor is aware of hypermobility, which is a good start, which is the, again, the most common cause of tailbone pain is that hypermobility. And again, for those of you who may just be tuning in, hypermobility is, when there's excessive movement at the tailbone. And I'll show you that on here. So for example, where I can hold this up, and if I can hold this up to my iPhone, all right. So basically showing here where the tailbone may look normal while you're standing or laying down, But when you sit and you put your body weight on it, it may have excessive abnormal movement in that position. So sitting versus standing x-rays can be helpful, for that. And basically that hypermobility is a sign that the joints are unstable, that there's that dynamic instability at that area. All right, someone else says they lost 70 pounds, and that's when their tailbone started hurting. It felt like it was going to poke through the skin. So again, can't give medical advice on Facebook Live, but in my practice, when somebody's telling me that they feel like their tailbone is poking through the skin, most commonly it's a bone spur down at the lower tailbone. Not always, but most commonly. And I will show you an image in here of what that looks like. There's also a chapter in here, bone spurs of the tailbone. And looking right here. So that bone spur is that little bit of additional bone projecting or sticking backwards just down at the lower end of the tailbone, just below that arrow. And back to the issue about the weight loss, if it may have been that with the increased body weight over the years, that the padding at the buttocks on each side meant that the tailbone was not contacting the chair. So even though the spur might have been there for many years, it did not become symptomatic in many cases until after somebody lost a significant amount of weight. All right, next person, and I'm not sure how much longer I'll go here because my phone is running low on battery, and also there's a snowstorm here in New Jersey, so I do want to have some cell phone battery left for driving home in case we get stranded or something crazy. Let's see. Someone says, though, I have anterior angulation of the and fracture and dislocation after a fall in 2014. I've had all kinds of injections over the years. Is there a maximum amount of injections someone should get, and any other recommendations? There's debate within the musculoskeletal and pain management community in terms of how often to have injections. When I was in medical school here back in the 80s, many physicians used to say that for the steroid component of the injection, 3 within a year as an upper limit, and more recently, a lot of doctors will say 3 within a 6-month window. I think that's a lot. Not even so much for causing problems. In many cases, it's not, but it would be a matter of if I had to do the same injection 3 times in 6 months, would mean I'm doing the same injection for someone on average every 2 months. I would say it's just that the injection is not particularly helpful if that's the case. Someone here says, great job, Dr. Foye, very informative, valuable information on the coccyx. Does the sacrum sometimes also contribute to inflammation of the coccyx? So some patients will have, in addition to their coccyx pain, they may have pain at the sacrum and especially at the sacroiliac joint. Basically, this is the lumbar spine. Here's the sacrum. Coccyx is down here. Sacroiliac joint is on either side. One of the things that happens when people have tailbone pain, they don't want to sit on the tailbone because it's painful. The body is smart. It wants to avoid pain. So you'll sit leaning towards one side so that the tailbone is no longer touching on the chair. And when you do that long enough, it can often cause pain at the ischium. So people will have ischial bursitis. It can cause pain at the sacroiliac joints, the piriformis muscles, the lumbar facet joints. So a number of other things can be painful. Again, there's a chapter in the book called back and buttock pain. That is chapter 15, and I'll show you the image here. Okay, I'm not sure if that'll focus, but basically showing some of these other areas that can be painful in patients. So they may have coccyx pain initially, but then by sitting abnormally, leaning towards one side or another, sitting leaning forward, sitting on the edge of the table so that their tailbone is not touching in the back, and those things can start to cause pain in some of these other areas. Is there a certain cushion for driving? There's a lot of different cushions. Certainly wedge cushions tend to be better for patients than donut cushions. If you go to either my website, tailbonedoctor.com/blog, and in that search box, if you put in cushions, or if you go to my YouTube channel, which is Tailbone Pain Doctor, and look in there. I have actually a series of videos all about different types of cushions, so hopefully that can help you. I don't know, there's probably at least a half a dozen different videos on different types of cushions, so it can show you some of the different options. Most common diagnosis for tailbone pain after childbirth, probably hypermobility, that patients may have a dislocation. Less common is a fracture, I've seen that as well, but more common is hypermobility in terms of the most common cause of tailbone pain that starts during labor and delivery. All right, I'm going to go a little more quickly through some of these just because my cell phone battery is dying and my voice is getting a little dry, and I've got to wrap up. What's my opinion regarding radiofrequency? Radiofrequency ablation of the ganglion impar may be helpful in some patients. Certainly it's been reported in the literature for many years. In fact, just last week I was at a conference with Dr. Plancart, Ricardo Plancart Sanchez from Mexico City. So if you're in Mexico, and if you can get to Mexico City, certainly Dr. Plancart would be the person to see there. He was the first person to publish on ganglion impar injections. He and I were speaking, met together last week at a conference, at a pain management conference here in New Jersey. All right, I'm on 10% battery life now, according to the pop-up. Thank you from the book, from the Netherlands. Okay, you're very welcome. I had a terrific trip over to the Netherlands this past June, speaking at and attending the International Coccyx Pain Symposium. Someone else listening from Missouri. I've had a number of patients who I've treated from Missouri. Loved your ebook, someone says. Terrific. Someone else listening from the UK. Awesome. I hope everybody, hopefully you've been able, regardless of where you are in the world, I would suggest today or tomorrow, today while you're thinking about it is the best, grab a copy of the book if you have not done so already, because today and tomorrow it will be free. You do not need a Kindle. You do not need Kindle Unlimited. Basically, just grab a copy while it's available for free for you, so that you can have it. You can read it on your desktop, etc. You do not need a Kindle Unlimited account. You do need an Amazon account, though, to get that. And also, the other thing I would ask you to do, if you have obtained the book, or if you already have the book, if you can post a review online of the book, that's very helpful, because it helps Amazon know that people are not only getting the book, but that they're actually reading it and hopefully finding it valuable. And that also helps other people know to whether it may be valuable for them as well. Okay, we have someone else. Who I know in the Netherlands and Houston, Texas. Terrific. So we're going to do this at this point. I'm going to wrap up with this Facebook Live session. And really, I want to thank all of you for joining in from around the world for Tailbone Pain Awareness Day number 1, the first annual. The goal is going to be to grow this more and more over the years. I would ask that if you're not already following me on Facebook or Twitter, please do so. Someone telling me drive home carefully. I appreciate that, since it is snowy and icy here in New Jersey this evening. But basically, follow me on Facebook. It's Tailbone Pain Center is the page. If you follow that page, anytime I'm posting updates, it should show up hopefully in your feed. The same with my YouTube channel, which is Tailbone Pain Doctor, or on Twitter, I'm at Tailbone Doctor. And on Instagram, I haven't posted anything yet on Instagram, but I hope to do so at some point when I figure that out. But I have the account, so you can follow me there as well. And again, if you already have the book, and have found it valuable, please post a review on Amazon. If you're interested in coming to see me specifically, easiest way to get the information for that, if you go to my website, www.tailbonedoctor.com, there's a box there, or if you go to tailbonedoctor.com/forms, you can get all the forms that you need to fill out to come in and see me. So again, if you can share any of the links that I've posted, either this video right here or any of the other links that I've posted here in the Tailbone Pain Center announcing the free book for today and tomorrow, feel free to post that wherever throughout your social media, because hopefully that helps to spread awareness about tailbone pain so that physicians can learn more about it and people can learn more about what may be causing their pain. So with that said, thank you all for being here for Facebook Live, and over and out. Okay, bye-bye now.